Good morning, everybody. This is Bernardo Cortese from Milano, Clinica San Carlo. I'm going to chair this session on this new technology, this new sirolimus-coated technology with a solution DCB. This is my potential conflict of interest. So what is important now is to underline the new technology which helps us to improve the quality of our PCIs. With a solution DCB, we have a DCB which elutes sirolimus at a low dosage, 1 microgram per millimeter square of the surface of the balloon. But the difference here with other different brands is that the release of the sirolimus is adjuvated by a new technology which is called CAT, and which helps the correct deliverability of the drug into the vessel wall with a membrane which is delivered upon balloon inflation. And then sirolimus persists in the vessel wall for up to 3 months, like some animal studies are showing. So this is important for us in order to have the drug with a controlled release for the first months after PCI. I have nothing to tell you about the properties of sirolimus and the wide therapeutic window and its safety. So what we want to see now is the performance of this new device for our complex daily clinical patients. So the objectives of this webinar are to understand how sustained Limus release technology can broaden the use of DCB in our daily practice. And then we want to learn how solution SLR sustained Limus DCB performs in our everyday clinical practice, thanks to the improved deliverability and trackability of this device. We want to understand which are the problems that we currently face with drug-eluting stents, and if we want to have something different in order to optimally treat our patients, because we want to avoid the full metal jacket, and in some cases we want to leave nothing behind to our patients. So this is the first case that we did a few months ago. It's a very highly complex patient with a stable angina, and we managed to treat this patient not only by a DCB strategy, but we used a DCB just where the side branch were there, and we didn't want to risk to close them. So we did a hybrid, full hybrid therapy, and this was the final result, which was actually maintained after 4 months when the patient came back. Today, we will have 3 experts which will show us how solution SCB is used in their daily practice. We'll have Dr. Mashayeki with a live in a box, followed by Dr. Rissanen, which will help us to understand the dilemma if to use a stent or not, and Dr. Hanner, which will help us to understand when and how we should use a hybrid therapy with drug-eluting stent and sirolimus-coated balloon. Thank you and enjoy our webinar. Ciao.
So hello, it's a great honor for me to talk about CTO interventions and how to avoid a full metal jacket during CTO PCI. And those are my conflict of interests. Well, what we actually know is that once we're putting a lot of stents in, a stent length more than 60 millimeters, then the rate of target lesion failure is going high, up to 16%. This is an analysis over 1,100 patients, and 36% underwent a full metal jacket. And the predictors actually for the target vessel failure were the number of stents, but also persistent distal lumen narrowing. And this was in a univariate, but also in a multivariate analysis, highly significant. So what's also known actually from the precedent 3 and 4 trial is that patients who are stented after CTO have higher rates of target vessel revascularization compared with those who are not treated despite the remaining disease. And here you can see a difference between 18% versus 8% regarding in-stent restenosis once you put a stent in. And it's interesting that still, even if the stenosis distal the band of a CTO are more than 50%, and you try to treat this with a stent, that you might end up with about 80% with instant restenosis in this trial, compared to those who are non-treated at all. In this collective, actually, the instant restenosis rate is lower. So that brings us to the thought, actually, and about what can we do as an alternative to reduce instant restenosis. And the basket 2 trial actually showed that it's feasible also in lesions with lower than 3 millimeter to make a drug-eluting balloon implantation, actually, this versus drug-eluting stent, and the MACE rate was not different in both arms. So what is, I think, very important once we think about doing optimization regarding drug-eluting balloons or even a stent or hybrid therapy is also to have intravascular imaging. Well, intravascular imaging helps you to see a huge dissection or big dissection distal to stent, true protrusion in the stent, but for sure also malopposition. So this is very important to have an understanding of the disease in the vessel. And what we know is that intravascular imaging actually can reduce MACE rate in CTO PCI. And this was shown already in 2015, where the combined endpoint was reduced with IVUS-guided PCI compared to angiography-guided PCI. And also in lesions and complex PCI where we need longer stents, more than 28 millimeters, there was a clear message that IVUS-guided PCI has a lower primary combined endpoint. It was cardiac death, TLR, and TLR-related myocardial infarction compared to angiographic-guided PCI. And, well, the trigger was almost a TLR, which could be significantly reduced. This was a huge trial of 1,400 patients we were randomized. So this, what I want to share with you is a live-in-a-box case, actually what I recorded, and where you see a CTO of an LAD, and there is disease, diffuse disease, and we did a retrograde crossing, ipsilateral. My colleague Mohammed Ayub was with me. I could pass with a Filter XT wire directly into the antegrade guide, and I could bring the microcatheter up and then do a tip-in. And finally, we had an antegrade wire, and now we were thinking about the strategy for stenting. Well, the complete part of the complete occlusion has the highest burden of disease. Here, we decided to use a stent because the OCT was not, we couldn't see anything because the flow was reduced. And we did also a stent proximal because there was a high calcified lesion. So then we run the OCT because of the distal band. And what we have seen here, pardon me, actually was that the distal vessel looked not bad. Here were some disease for sure. And here was also, you might see, it's a little bit diseased here, the vessel. And here you see calcium also. Here calcium is coming. It's a 180 degree of calcification, as you can see here. And there is a remaining dissection directly at the end of the stent. Nevertheless, we decided for a solution, a drug-eluting balloon with a sirolimus platform with 30 millimeters to save a stent flank. And this is the balloon here, as you can see it. And we will show you the angiographic result and also the OCT result. Here is the primary angiographic result with a TIMI-free flow with a remaining dissection, which is not very good visible on angiography, but you will see it on OCT. So here is dissection distally, as you can see. There is a relatively good lumen, but already small dissection there. And going up, here is the 180 degree of calcium. And even with we used only 4 to 6 atmosphere, there was still a remaining dissection distal of the stent. The stent itself was expanded very, very well. And I think it's a nearly perfect stent result. So the question is here, should we put a stent or not? I want to be provocative here and tell you that once you have TIMI-free flow and like here, in a CTO vessel with a diffuse disease, and you might end up probably 40 to 60 millimeter more stents, it's really worth try it with a drug-eluting balloon primarily because the long-term outcomes actually are not bad. For sure, we need further studies for this hybrid approach, that's clear. But what you can see here, that the primary result is very good, and we have to bring the patient back for re-angio. He felt very good and no troponin elevation the next day. So taken together, the number of stents and distal lumen narrowing were independent predictors for target vessel failure in full metal jacket CTO lesions over 60 millimeter drug-eluting stents. That's what we know. Drug-eluting balloons should to be effective as drug-eluting stents in the de novo lesions smaller than 3 millimeter in the basket 2 study. I think imaging-guided CTO PCI has shown clear that it's possible with image-guided CTO to reduce hard clinical endpoints. That has been shown already in 2015. And whenever an increased use of drug-eluting balloon combined with imaging in CTO PCI may reduce TLR, has to be improved by further studies. Thank you very much.
Okay, so welcome everybody. Hi, Cambis. Great presentation. Thank you for showing us the use of solution DCB for a complex CTO, retrograde CTO. I would like to ask if the panel has any type of question on this case, because I have one that I would like to ask you. Okay, so I go on with this question. Cambis, you are an expert either in DCB and in CTO management. So my question is, do you think that DCB can have a smart future for the use for its use in CTO in reducing the DS length in this type of lesion setting? Because we know that we want to avoid too long stents in this setting. Okay, I know that you do such cases, we do such cases, but only a few of CTO experts are using DCB in this field. Do you think that in the future, especially with a new device like the solution with a sustained release of sirolimus, there could be any advantage for the treatment of CTOs?
Well, thanks, Bernardo, for the question, actually, and it's an important one. That makes me, in general, the question makes me thinking about trial design and also what we have to compete with. And we have to compete with ultra-thin drug-eluting stents nowadays, but nevertheless, especially data showing us that very long stent lengths are associated with higher TLR. So the question is, how can we predict a low TLR rate with drug-eluting balloons? And therefore, this brings me again to 2 points which are important. One is the right plaque modification tools and to really modify the plaque before putting the drug. And this is directly connected with intravascular imaging. So if you ask me what is going on in future, what is going on now, what I would like to have is I would want to better understand at which point actually regarding which criteria do I need in HD-IVUS or OCT to be safe, and for the patient also regarding long-term outcome with only drug-eluting balloon. I mean, we know that in smaller vessel, like in the basket 2 trial, it works, but as you have seen here in my case, there was still a remaining dissection. We know that end-edge dissection of stents can even lead to instant thrombosis. And this was not a flow-limiting dissection, but at which point, I mean, it turns into a higher risk for the patient, and so therefore we have really to calculate the risk and benefit of remaining dissection, and also to regarding the opposite to save stent length. So at this point, we don't have a clear answer for this question at the moment.
Okay, thank you for your clear answer on this. So we need to work, we need to also to design some mechanistic study on this setting and to see which device will be the best solution for our patients. For the sake of time, we will go on with Tuomas Rissanen, which has a recorded lecture on how DEB-only strategy for complex lesion changing the treatment paradigm.
Dear colleagues and friends, I'm very happy to share a couple of complex cases treated with DCB-only strategy with you, and especially with the Limus release DEB. These are my disclosures. The first patient is a 65 years old male. He has hypertension, type 2 diabetes, hypocholesterolemia, and anticoagulation for chronic AFib. He presented with stable CCS2 symptoms, and diagnostic coronary angiogram revealed a CTO lesion in RCA. Elective PCI of the CTO lesion was planned, and this is the bilateral contrast. You can see that the lesion is quite long, but there is a microchannel inside of it, and therefore a undergrade wire escalation was the initial strategy, and we were able to pass this lesion with Fielder XTA wire quite easily. However, in the B part, there was a possible subintimal wiring of the lesion, which may have an impact in the outcome in this patient. This is the result after predilatation with 3.0 NC balloon all the way the vessel from the distal part to the ostium. And because this fulfilled the international consensus guideline criteria for DCB-only treatment, we applied 3 very long drug-eluting balloons. The first, most distal one was the solution Limus eluting balloon, and then 2 paclitaxel eluting balloons. And the reason for the mixed balloons was that we didn't have enough very long balloons in the self. The patient was NOAC, and we found this DCB-only strategy very beneficial because we avoided the full metal jacket in this patient. This is the final result of the vessel. You can see that the flow is normal. There is no significant recoil, a little bit dissection, which is non-flow limiting in the B part. And it's very important to have also a different view, showing that there's no problem in the vessel, and also the AP view is very nice in these DCB-only lesions, where you can very nicely see if there's a problem in the vessel. In the control angio, you can see that treated RCA was enlarged in size due to positive remodeling of the vessel. However, there was a spot in the P part where is restenosis evident. We did OCT run in this patient, and in the upper left corner you can see the part where solution balloon was treated. The vessel has healed. Of course, you have to bear in mind that this was the distal disease of the vessel and not the occluded part. And then on the right corner, there's a part where is stenosis evident, and then the paclitaxel treated parts. And it's very important to notice the size of the vessel, which is it's actually very large, up to 4.3 millimeters. And we believe that this subintimal wiring could have an impact on the focal restenosis in this patient. We fixed this restenosis with a stent because we did also a predilatation again, but there was a recoil, so the lesion needed to be stented. Although we were very happy to see that only 12 millimeter stent was finally used in this very long lesion. The second patient is a 74-year-old male, hemodialysis for renal disease, heart failure, hospitalization, and very importantly had anemia at the time of presentation. Coronary angiogram revealed a significant distal left main stenosis, Medina class 101, and also you can see that the ostial circ is significantly diseased. But the proximal LAD was actually fine. You can see it here. And because of this calcium, we decided to have upfront rotablation using 2 different size burrs, 1.5 and 2.0. And after that, predilatation was performed with a 4.0 cutting balloon, and this is the result after predilatation. There's a little dissection seen in the circ, but flow is good, and the left main looks nice. Due to high bleeding risk in this patient, and also not to endanger the ostial LAD, we decided to apply solution DCB in this lesion, covering both LAD left main and circ lesions. This is the final result, and you can see that the circ is fine. A little bit non-flow limiting dissection, and no problem in the LAD. We found that it's very important in this case as well to have a control angio, and this is the situation 5 months later. There is no restenosis in the left main or in the ostial circ, which looks very nice, and also LAD, ostial LAD is still okay. So I would like to conclude that DEB or DCB only strategy for de novo lesions is safe and efficient, as shown by the recent randomized trials, but it's also feasible in complex lesions after rotational atherectomy, or even in CTO in cases where you can have a lumen-to-lumen wiring. And finally, Limus eluting DEB is a novel option for the stainless PCI. I would like to thank you for your attention and ready for questions.
Thank you, Thomas, for having shown these such complex cases. I would say extremely complex cases with extreme indication for a DCB, but we know that you have a long-term experience before with paclitaxel in this lesion setting, but also in the complexity of the patient, for example, the high bleeding risk patient. So the key messages of your presentations, in my opinion, are dual. The first one is that you have to achieve a perfect lesion preparation, and you did it with all of the devices that we may use, rotablation in the second case, and aggressive predilatation in the first one. The second message, which I would like to underline from the second case, is that in that particular position, you avoided putting metal, which could in some way hamper a perfectly spared ostial LAD. So by means of using just delivering the drug, you avoided this, and you did correctly an angiographic follow-up to see if there was a restenosis. So can you comment on this?
Yes, thank you, Bernardo. Very good points. And yeah, we have done almost 3,000 PCI using DCP only strategy in our cath lab during the past years. And we have found that especially the frail patients, high bleeding risk patients benefit from this. And in the second case, the patient was actually in hemodialysis, had anemia in the presentation. And as we achieved a stent-like result after rota and predilatation with a cutting balloon, we found that there is no sense to put a stent in this patient, but treat it with a solution. And we quite often have control angios, especially in CTO cases, to see the good result, because as you know, the data is limited at this point. So we have to gain experience and of course, have good trials in the future.
Yeah. Any comment by Jonas on these cases?
Yeah, well, it's really interesting how you can do even left main PCIs with just drug-coated balloons. This is impressive, and it needs power to do that also in a case. I will later on present the case where I did the hybrid management. But if you have in one side branch or in the main branch some dissection, would you be very aggressive in changing your treatment strategy, or would you try to stay on DCB?
Thomas.
Yes, very good question. We keep all the ways open until to the end, and we have to keep in mind in the clinical aspects of the patients. The bleeding risk, the threshold for stenting is in fact lower if you have a young patient, healthy patient, but it's higher if you have a frail bleeding risk patient. In bifurcations, the side branch is a very good target for DCB, but also the main vessel, if it's the result of the preclaration is fine, there is no recoil over 30%, the flow is Timi3. So we have found that there will be no problems in that vessel later on. Occlusion rates are really low. They are 0.2% of the DCB only strategy.
Yeah. Well, I want to underline one point. I think that we need to do this. We are not claiming that we should use such a new device in such a complex setting, because you know that solution came out 1 year ago. The clinical program just started. It is very ambitious. It will cover all of the coronary lesion settings that we face, starting with in-stent restenosis and de novo lesions with very large trials. We will see the results in the next few years, obviously. And so the message is not, okay, we should use this new device also for left main. But in everyday practice, we have to face with very complex patients like the one that Thomas just presented with high bleeding risk, dialysis, and so. So we don't have just to think how to put a metal there, but there is also an alternative. And drug coated balloon or drug eluting balloon, however you want to call it, is a good alternative. Okay, so we are perfectly on time. So I would like to present you the last lecture of this session, which is done by Jonas. It is combining DES and DCB, a hybrid treatment. So this is one of the most important and interesting settings where a DCB can be used in my personal view.
Dear audience, I'm Jonas Hanner, interventional cardiologist at the Bern University Hospital in Switzerland. It is my privilege to present you 2 cases under the topic combining drug-eluting stents and drug-eluting balloons as a hybrid treatment strategy with sustained Limus release drug-eluting balloon. I have nothing to disclose. I will show you 2 different cases with hybrid treatment strategy where I used the combination of drug-eluting stents and drug-eluting balloons. The first was a left main trifurcation where I chose a drug-eluting balloon for the treatment of a side branch to avoid 3-stent left main trifurcation PCI. The second one was a patient with multifocal small vessel disease with 2 almost identical lesions in 2 different posterolateral branches, where I would like to show you how I tailor device choice according to the result after predilation. The first case with a left main trifurcation was a 61-year-old man. 2 years ago, due to progressive asthma, he quit smoking and started cycling. One day, however, while cycling, he had an inferior STEMI. We diagnosed 3-vessel disease, initially recanalized the thrombotic RCA occlusion, and got him back to the cath lab 6 weeks later for staged PCI of the left coronary artery. At the time of staged PCI, this is what the RCA looked like. Ejection fraction was slightly reduced. And this was the reason for the reangiography 6 weeks later. This was the left coronary artery. We had a significant left main shaft stenosis, high-grade stenosis of the intermediate branch, significant circ stenosis, and diffuse disease of the LAD. LAD had an RFR of 0.88, which was significant. We did not do FFR due to the asthma. We offered surgery to the patient, but he insisted on percutaneous treatment. Planning OCT confirmed diffuse disease of left main and LAD. We had a minimal lumen area of less than 5 millimeters square in the left main. We had significant disease at the site of the left main bifurcation, and LAD had calcified segments as well as lipid-rich segments. So what was the approach to this left main trifurcation? The European Bifurcation Club proposes to keep bifurcation stenting simple and safe. So I think this also can be considered for trifurcations, to try to limit the number of stents used and to aim for well-opposed and well-expanded stents with limited overlap, which may be difficult if we treat this trifurcation. So my plan was to simplify trifurcation to a bifurcation by avoiding intermediate branch stenting. So step one would to first predilate and treat the intermediate branch with a drug-eluting balloon, and then to proceed with left main bifurcation PCI. And this is what I did. I first predilated the intermediate branch with a 2.0 compliant balloon. After confirmation of a good result with less than 30% residual stenosis and absence of relevant dissection, I applied a 2.0 20 millimeter solution SLR drug-eluting balloon for 60 seconds. And this is the result thereafter. I could confirm a good flow and no relevant dissection. Thereafter, I proceeded with the treatment of the left main bifurcation. Keep it simple here. I used a long stent from the left main to the mid LAD, and then second stent to the circ, followed by pot, kissing balloon, and OCT-guided correction of residual malapposition. This is what we had at the end. OCT of the left main and LAD showed a good result in all segments, and we had a very minimal double layer segment at the site of the distal left main bifurcation. Angiography showed that the intermediate branch was still perfused. The patient was discharged the following day on aspirin and ticagrelor. And follow-up 6 months later, unfortunately without angiography, was uneventful. In my second case, that was a 70-year-old man with history of posterior STEMI, PCI of the circ and LID 1 month ago. He now presented for staged PCI of the posterolateral branches. Those were almost identical lesions and affected small vessels. When considering the use of drug-eluting balloons for the treatment, 2 points are important. First, we need an optimal predilation. And second, we need to assess the result after predilation before we proceed. Predilation may require specialty balloons or further equipment if necessary. And once we have an acceptable angiographic result with no flow-limiting dissection and less than 30% residual stenosis, we can consider proceeding with drug-eluting balloon. Otherwise, in case of suboptimal angiographic result, we should prefer drug-eluting stent. In my case, I used a 2.0 compliant balloon for the predilation of both lesions. Here, in the second posterolateral branch, I had an acceptable result without relevant residual stenosis, while in the first posterolateral branch, the result was suboptimal with a significant residual stenosis. Accordingly, I used a drug-eluting balloon for the second posterolateral branch and a drug-eluting stent for the first one, with a good final angiographic result. And the patient came back 1 week ago for a planned re-angiography 6 months after, and we still have a good result and a good runoff in both lesions. To summarize, I showed you 2 different cases where I combined drug-eluting stents and drug-eluting balloons with sustained Limus release. The first case, to avoid 3-stent trifurcation PCI, I first treated the side branch with a drug-eluting balloon. Reduction in PCI complexity may result in a better stent geometry and the remaining bifurcation with a lower risk of stent failure. And sustained Limus release may improve long-term patency of side branches. And the second case was to illustrate how I guide the decision whether to use the drug-eluting stent or a drug-eluting balloon according to the result after predilation. Drug-eluting balloon should only be considered in cases where we don't have flow-limiting dissection and a less than 30% residual stenosis after predilation. Thank you for your attention.
Great, Jonas. So also these 2 cases which you just presented show an important message that I would like to underline. which is that when you do a PCI, this is what we believers in DCB want that all of the audience will come back home with this message, is that you should change your mindset. You don't have to think of how to accommodate a stent. You have to prepare the lesion, which is also important in the complex lesion setting with DES. Okay, you prepare the lesion, then you may decide. If you don't have a good lesion preparation, you can go on with a stent because modern stents, as Cambis already said, are safe. So we may use them. We have to use them every day. But if the lesion preparation is okay in a de novo lesion setting, you may go with a good drug-coated balloon like the solution, and the result will be very good. So this is an important message. Are there questions from the audience on these cases?
I could ask Jonas, if I may. When you are treating side runs with DCP, do you apply the DCP before stenting the main branch or after it?
Yeah, this is a very good question. Thank you. I think it depends also a bit on the complexity of the lesion. I mean, in a trifurcation, like in the first case, I decided to first treat or at least predilate the side branch and see how it looks like after predilation and also after application of the drug-eluting balloon to still have the chance to step up to a more complex stent-based treatment. However, in more easy lesions like bifurcations, it may be a consideration to just predilate the side branch, treat the main branch, and then come back with a drug-coated balloon in the side branch, which may have the advantage that we don't have to manipulate again with another wire or even with the stent balloon to the proximity of the applied drug-coated balloon.
Yeah, because one consideration could be that if you stent the main branch first, it could be difficult to have the DCP delivered in the side branch, and also that some of the drug may rip off the balloon.
Yeah, I think that you are right, Thomas. Unfortunately, we don't have data on this setting because some bench test data probably would be good for us in order to understand if also after the dilatation of the side branch there is the risk of losing some drug. So this is an important point in my opinion, but we have no data on this. I would like to ask you, I don't know if Cambis is still there.
Yes, I'm here.
I cannot. Okay,
yeah, I'm here.
Sorry. I couldn't see you. I have a question for you, Cambis, and also for Jonas and Thomas. This is a quite recurrent question, but I think it's a little bit didactical, so I come back to it again. Many physicians are asking, for how long are you doing prolonged antiplatelet therapy with DCB? Okay, so we have some questions, some easy questions with paclitaxel. We have seen in several studies, we have several consensus documents claiming this. So which is your experience with sirolimus?
Actually, what we're doing at the moment is still that in patients with low bleeding risk, we still go on for 6 months, even if we use a drug-eluting balloon. And it depends on if we have higher bleeding risk patients, I think we can reduce this definitely. And but I think that Thomas in general has more experience, as they have done more than 3,000 PCIs with drug-eluting balloons, so probably he can tell us a little bit about his clinical experience whenever he reduced the short depth or only go with monotherapy, so probably he can comment on this as well.
Thank you. This is a very good question. Our practice is to use 1 month DAPT in normal case for elective patients. And of course, for ACS patients, we follow the guidelines. But in those patients as well, in case of bleeding, you can actually more easily stop DAPT if you haven't stented the vessel. But in the extreme risk patients, like a patient going for emergency surgery tomorrow, we may use only a single antiplatelet, either aspirin or clopidogrel. And I think surgeons like that approach a lot. And in complex cases, we can use cangrelor infusion during the procedure and then stop and continue only single antiplatelet. But this approach is quite extreme, so we only have maybe a couple of dozens of patients per year, so it's not normal for us either.
Yeah, I totally agree with you, Thomas. This is something that we do as well. In the case of extreme risk of bleeding, we go with single antiplatelet therapy, and we have never seen any problem. Because we have to think that we are not putting metal. Obviously, I'm not talking about hybrid therapy patients, but just DCB. Okay. In these patients, we are not putting metal, and the second antiplatelet was invented for the metal addition. First with bare metal stent and now with drug-eluting stent. So also, if we cannot claim that we can use only one single antiplatelet for DCB PCI, but in some very selected cases, we may do this. You have a great experience on this, and I'm happy that you share this message to the audience. Now I would like to go for another question to everybody. Which is a complex question. I don't have a correct answer, but okay, you have a new device, you have a solution with some inherent characteristics that we have seen, and you want to design a clinical trial. Okay, so all of you have a good experience with DCBs, you have participated to trials, you have a great experience in the cath lab. So how would you design a new study with this device in order to understand its characteristics?
As you all know, I'm interested in HPR patients, so we are actually starting a randomized trial in Finland very soon, where we compare DCB only strategy against stenting in high bleeding risk patients. So I think those patients get the most clinical benefit from this using short DAPT. But what we need is randomized trials against stenting in the different scenarios, large vessels, small vessels we already have. But that's my point.
Yeah, I think the same we need also for the CTO lesions actually. And I think we had to start probably with imaging trials to define whenever we can use DEB in combination, especially also with distal the band where we have diffuse diseased vessels. And but I think this might be imaging endpoint trial, not a clinical endpoint trial, because therefore we would need too much patient.
Okay, Jonas, what do you think?
Yes, well, I also think since it's a new device, first we need the imaging-based trials with imaging endpoints before we go to a very, very broad spectrum of patients, and also to keep the indications for the trials also a little bit focused on single groups of patients, not to have a very biased sammelsurium of different cases.
Okay, so I'm happy that we agree also on this point that we don't need now a trial with angiographic endpoints. Okay, well, we need them, but we also need the intravascular imaging because the complexity of the patients that we are facing need to have a more profound lesion assessment and final assessment of the result that we have obtained. So this is what we need, and this is also agreeable. Then the second study that we need to do is a randomized clinical trial with clinical endpoints. This is very important and agreeable, I think. So yeah, we are at the end of this very interesting session. For the next time, I'm asking Med Alliance to organize a 90-minute session because 45 minutes are really too few for us to cover all of the topics on this new device, which is very interesting considering its characteristics in delivering the sirolimus as the first studies have shown for the first 90 days after the inflation. I thank you for your attention, and I thank all of this extraordinary panel for taking part into this session. Ciao.
Thank you. Bye-bye.
Ciao. Bye-bye.